I dare say John and Jesse instead of Chairman. I'm very grateful for you too, because I remember I was inspired in my first year as a resident in plastic surgery by your talks in London, and I'm very grateful for that. And I'm now almost done with my training, and I have a special interest in this. I'm very grateful to RAMSES and the scientific committee, and I really like this picture, which shows you here that the kind of most important psychological barrier that cleft surgeons around the world are facing, which is the very fragile little baby and the very scary large robot. So robotic is the one. So pediatric robotic surgery is really relatively new, and the indication started with large cavities, with the first case reported in 2007 with Nissen's fundoplication. And since then, urology and pediatric surgeons have taken this into different indications in gastrointestinal, gastrourinary, and thoracic surgery. And of course, the utilization is being mostly driven by the advantages of robotics that we have been hearing about all the last 1.5 days. And as Jesse introduced with transoral robotic surgery, there is a particular advantage around areas with very confined space. In the adults, that is almost standard with FDA approval of some of the oropharyngeal cancers, especially T1 and T2, and all these different spaces has been approached. And for you to think this, being able to operate here present almost no challenge to being able to operate here, where the cleft palate and the soft palate are situated. Now, to understand why we try to create a new indication in robotics, I really like this graph, which tries to plot the invasiveness and efficacy with the patient's comfort zone. So whenever we try to create a solution for a patient pathological problem, we usually forget about them until really almost in this last 10 years we started talking about patient-reported outcome measure, so that this is guiding us here. And then even with the alternative that has been celebrated by our very happy oncologists, that still fails to reach the area of comfort zone. However, robotics suddenly appear, and we can achieve the solution of the problem, and the patient also reaps the benefit of that. So there is a huge value for the adult patients in TORS, in low blood loss, no visible scarring, disfigurement, no tracheostomy required, minimal or elimination of need for chemoradiation therapy, low rate of complications, short length of stay, and all this has been now validated in clinical trials. You could see this very interesting trial from Dean et al. Showing here with salvage operation the huge difference between robotic assisted salvage and the open salvage. Even though there is no statistically significant difference, you could see here that the robot is superior to some of our traditional tools. And I really concur what Jesse and John said about the technology. And I think, I used to be a horse rider when I was a teenager. And I think globally we have much less horse riders now compared to motorcycle and bicycle users. And maybe I dare many of you who are very good on the motorbike to be able to tame a horse or take it for a 10 miles. So we will lose traditional skills as new, better ones arrive, and there is no problem in that. Okay, and as you could see, once you have established a advantage and an indication, and you have peer review and legally approved, you will have an increase in the use of the tool. And the technology then will be extremely popular. And here, this graph shows just 1 decade of propagation of the Da Vinci system in the United States. In fact, the Da Vinci and its clinical applications continue to be an American thing, because most of the papers are coming from the States, driven by the economy advantages that our American colleagues have. Innovation in robotic use in head and neck surgery from TORS, from the FDA application, allowed daring surgeons to go and try to find new indications, such as transaxillary thyroidectomy, or, for example, sleep surgery with obstructive sleep apnea and the reduction of the oropharyngeal tissue. In the same way, this has then moved to the pediatric patients. So there has been a reluctance initially to try to reap these advantages for the pediatric patients. And up to last month, only 60 patients of the pediatric age below 16 has been going under the robots. And this is relatively very, very low number in comparison to the hundreds and maybe thousands of patients who are adults going for TORS. And as you could see here, the indications are mostly safe indications, and they are usually relatively superficial. It is the lingual tonsillectomy for obstructive sleep apnea with very simple resection. So we don't have complex, delicate tissue handling, such as intravelar viloplasty or the three-layer repairs that some of the surgeons advocate for better speech outcome and speech palate repair. And as you could see here, this is a review from 2017 in relation to the pediatric head and neck use of the robot. And all of these papers, except one, came from Turkey. And there is one report last week, actually, coming from Italy with 3 more cases. And in all this, there was a complete successful operative by the robot in 92.9%, only 4 cases out of the 60 needed to be open, and there is no major complications, so which is really very promising. Now, the lessons learned so far from the TORS is that we have encouraging first reports, and we have instruments size is a limiting factor. Many times that has come in the discussions of these papers. We need to think about keeping the patient safe from the robot and also from the surgery, because the robot goes there and it's very easy to be distracted by the arms, and we forget about simple things like endotracheal tubes, which has been displaced in a couple of cases. Appropriate exposure of these fields, appropriate tools for unrestricted mobility, and a bedside surgeon to protect the airway and to protect the patient has been highlighted as an important in pediatric TORS. So now from the TORS, there is an evolution to something called TORCS, which is the transoral robotic cleft surgery, which has been coined in Oxford. This is the first report of TORCS coming from Philadelphia with the 3 cases in cadavers and using the adults. So here they just demonstrated the feasibility of using a posterior pharyngeal flap for velopharyngeal incompetency. And they were not brave enough to try it in the adult or even in the kids, which is very appropriate. And as you could see here, they reported advantage in visualization, twice the operative field compared to conventional microscope or loops. Maneuverability, neck fatigue of the surgeon has been also noted, and then the risks of steep learning curve, the contact of the instruments with one another, haptic feedback loss, and the cost advantages. There was a lesson learned about the need for the cleft surgery robotics instruments to be adapted for indication specific. The second report was just last year really, but it's been done in 2012. Here again, the team tried another indication, which is Heinz pharyngoplasty. These are 2 superiorly based flaps used to augment the posterior pharyngeal wall in order to bridge the gap when you have velopharyngeal incompetence. And as you could see here, they used mannequin, the resuscitative pediatric mannequin, and this is the first time this research is trying to adapt the robot for a small size. And also did the same operation in an adult, and they showed also advantage in visualization, maneuverability, patient's position, as well as the risks of the red tape in the United Kingdom, where it was shown to be very difficult to try to make this happen in a patient, the contacts of instruments, and the cost as well. We could see from the second report, we have already optimization of the protocol, where to put the patient, where to put the machine, whether to put the patient's head near the foot of the tray or towards the head of it. So the evolution is quite quick, and the most important conclusion is the role of the second assistant at the patient size to prevent damage to the oral cavity. After that, we have a very, very daring surgeon from Antwerp, and I here remind you of Jean-Pierre's presentation yesterday with the naked man dancing. So this is our colleague who is starting in the patients directly. So he had one cadaver. He had one cadaver on the adults and moved on immediately to do torques on 10 infants with the age of 2 to 18 months with a zip pharoplasty for a variety of indications. He had 5 patients with cleft palate and 4 patients with unilateral cleft lip and palate and 1 patient with bilateral cleft lip and palate. But he here was very cautious. He only did the intravelar or the 2 flap dissection and the elevator sling reconstruction with the robot, but the nasal and oral layer, he was not brave enough to use the robot. He used it with hands-on. And as you could see, he showed that the unit parallel to the table at the patient's head with a extension of 15 degrees, 30 degrees camera, facilitate the use of both the 5 and the 8 millimeter tools. He noted that when you use the 8 millimeter tools, there's no space but for 2, and he reports 120-minute operation versus his manual 90 with a docking time of 35, showing quite a feasible operation, reporting no complication whatsoever and statistically significant shorter hospital stay than the conventional stay. So we are starting to see advantage for the patients for the first time. Highlight is the role of the second assistant again, and then the oral and nasal mucosa manually repaired. Now the most important paper I would consider has just come this year in January from the Hospital for Sick Children in Toronto, and I was very proud to be one of the N which has been validated here when I was fellow there last year. And the team, in order to study the feasibility of this, have created this amazing customized, bespoke, real-life infant simulator that allows us to then try all sorts of technique adaptation without the risk of patients or without the issues of pediatric cadavers. Now, the very important aspects, the model has been tried for both SI and XI, and all the work has been done in the simulator. There's no cadaver or live patients tried, and the procedure was the most challenging, the von Langenbeck with Summerlad intravelar veloplasty, and they report advantage on visualization, maneuverability, and teaching with risk of collision, etc. Now, the amazing thing about this paper is that when you are able to create a simulator such as this, you can then study the procedure much better. So they divided the procedure to 10 important steps, and they validated and criticized the performance of the report in each of them. So they were able here to go and stitch the mucosa of the nasal layer and the oral layer without worrying about fistula, as our colleague from Belgium avoided. And 3 of the important aspects here is the role of the second assistant again, oral and nasal mucosa repaired in the robot, and the smart haptics development call. So they ask for a smart haptic, like our cars now, which will warn us if we are trying to reverse into a wall or something. And as you could see, because of their ability to now take the time, not worry about the infant, they have very impressively characterized the performance of the robot along all the procedure, showing here, for example, that the XI was superior in relation to arm reposition of the surgeon, of the instrument collision, instrument oral apart collision, and also, like you could see here, how they demonstrate the contact between the arm and the oral cavity and any side effect that might come out of that. Further characterization is shown in their paper as well, and they shown very impressively that the arm wrist of the SI will create the problem when you are trying to reach the periphery of your operating field, a problem that has been eliminated by using the XI tools. You could see here, can you please play the video on the left-hand side? These are just 5-second videos that will show you how this is very. Can you please play the video on the left-hand side? You could see here the extraoral movement of the SI robot in real time and how the instruments are used in the simulator. Can you please play the right-hand side one? And this is similar work with the XI. A very interesting discussion from Jesse to this paper, and I think he has raised very interesting points in his discussion, which that the creation of the simulator and the stepwise competency assessment potential of this paper is really important when we are developing indications for robotics. So we have to think not only of the indication, but how we are going to teach the new surgeon and how we're going to evaluate their competency. And because of this very fact, we are working now with the authors in order to validate the simulator using hand motion analysis in a collaboration between Queen Mary University and Sick Kids. You could see here how the electromagnetic hand motion analyzer is being used, and that will give us an objective assessment, a validation of this simulator that the authors were not able to produce in their tools. You could see here the senior author, David Fisher, and can you please play the video on the top left? And Karen Wong using the electromagnetic device, and you could see how elegant dissection. Can you please play the one of the bottom right? You could see here David performing the intravelar veloplasty with a high fidelity indeed. Okay, let's move on. So, in conclusion, the robotic in cleft surgery now is a reality, and I concur what Jesse has said. We are not talking about feasibility anymore, but about optimization. We have a problem with the haptic feedback. We have a problem in the bespoke instrument, and we need also to optimize the costs, because now we have only $200 cost for a manual cleft palate repair. The advantages are much more than the disadvantages, and all related to the robotics and the indication here, and the cleft domain is very ripe for further investigations to optimize these limitations. Thank you very much, and I'm sorry for the few minutes over the time.